Hello, everyone. Welcome again to another conversation as part of the Femtech Next conference. As we know, we have been looking at different aspects of women's health, both the cultural and the clinical. And today we are very grateful to have Dr. Jaydeep Tank, who is the president elect of Foxy and has been practicing as a gynecologist for close to 40 years. So, what we hope to, talk with Dr. Jaydeep today is really about how women's health access, diagnosis, and management has evolved in his years of practice, and how do we take a futuristic look forward. Thank you so much for your time, Dr. Jaydeep. We're so pleased to have you this afternoon. We really appreciate your time.
Thank you. It's a pleasure to be here.
Thank you. So, Doctor, since you are taking up a very critical position, when it comes to women's health in the coming times, which is as a president-elect of Foxy, we just love to hear a little bit about what your vision is as you take this very critical position, given the centrality of doctors and the centrality of doctors' opinion in the way people treat their healthcare. So, what's your vision? We'd love to hear that a bit.
So, let me start by introduce Foxy because everyone who listens to this may not necessarily know what Foxy is. Foxy is the Federation of Obstetrics and Gynecological Societies of India, and we are an association of professional obstetricians and gynecologists. We are headquartered in Mumbai, and we have close to 36 to 37,000 members, all obstetricians and gynecologists spread all across the country in around 262 local chapters. The pillars, if I may say so, of Foxy have always been it exists for women's health and it exists for the well being of its members. And we tend to look at our vision and our mission through both these perspectives, which overlap quite often. The vision for here consists of trying to take what has been done in the past forward. Foxy is an old organization. We are approaching our 75th anniversary very soon. And,
Wow.
given that it's an old organization, it comes with a lot of heritage. It comes with its own set of rules. And I would like to use Foxy to expand in both these issues, both community facing and physician facing. So there will obviously be a continuity in what has happened in the past. I am quite proud of the fact that Foxy is such a old organization and such a art, how a very well regarded organization, if I may say so.
That's
And I hope that during the year when I am the president, it continue to be so.
yeah.
Uh, we will, of course, be looking at educating physicians as we always do every year. And this education of physicians typically takes the form of continuing medical education or what are called CMEs, conferences, uh, webinars, which have really become very popular thanks to COVID.
Yeah.
There is also the responsibility which Foxy has of producing what are called good clinical practice uh, guidelines or GCPRs or good clinical practice regulations or what have you. So we produce documents and the GCPRs look at the clinical issues and then we have policy statements which look at issues even outside medicine. So for example, we have policy statements on abortion, we have policy statements on implants, we have policy statements on other forms of contraception. When COVID happened, we were in fact one of the first medical organizations to come out with a statement which talked about the importance of sexual and reproductive health and
Yeah.
the continuation of SRH services even during the pandemic, either
Mm.
virtually or physically as much as was
Yeah.
possible. We did speak about the sometimes what is regarded as difficult topic of abortion and we were quite insistent that these facility must be continued to be available for women throughout the country. And here I must say that the obstetricians and gynecologists at that time really stepped up. And if you look at all the reports post COVID, because there was a lot of apprehension during COVID that these services are going to suffer in a very major way. In fact, if you look at some of the projections which happened 2 or 3 months into COVID, they warned of very dire outcomes, particularly with SRH. But I don't think these dire predictions have been reflected in reality. And I think a lot of it has to do with the fact that obstetricians and gynecologists continued to provide support. So there is this whole aspect of continuing medical education. There is an aspect of advocacy where we would like to continue dialogue with various stakeholders, including government, NGOs, activists, and I would like to expand this into the community. We have traditionally not regarded the community as a stakeholder when whatever we do actually affects the community the most. And I think it is high time that women's voices, the voices of community, are heard in medical circles, and they should be interested stakeholders in whatever medical profession talks about. And I think that voice has to be taken into consideration. So I hope that that will be one change that will happen when I'm not saying it's not happened in the past, but I think I hope that it sort of steps up a little more in the
Yeah.
year when I'm the president. We also have various community outreaches like camps, etc., which will continue. And then there is, of course, fellowship and for the well-being of our members, uh, preventing violence against doctors, reducing violence against women, and so on. The overarching theme of my year, or I hesitate to say my year because it's not my year, it's actually Foxy's year, where
Yeah.
I am the president. But in that year, we'll focus on women's rights and choices. And I hope that the theme, I'm not really framed it or articulated it properly yet, but my theme will focus on sexual and reproductive health, and it will focus on fertility because I believe that regulating fertility and promoting fertility for those who are not getting pregnant are two sides of the same coin,
Yeah.
and we have to take both of them equally seriously. Another
Yeah.
unfortunate
Absolutely.
sometimes that infertility is perceived as a problem of the elite, when actually it is a major problem for it's a problem all across socio-demographic strata. It's not
Yeah.
restricted to the rich. In fact, like with everything, the poor suffer the most because at least those who can afford it have access to treatment, but those who cannot afford it don't have access to the treatment. And we don't talk about infertility, I believe, as much as we do about the other issues as a public health problem. But if you
That's
look
right.
at the WHO estimates, 8 to 10% of all couples in reproductive age group have some form of infertility. And that's a
Yes.
massive number. Given the fact that we are over a billion people and a lot of us are in the reproductive age group, India is supposed to be a young country. And if you're not addressing infertility as a public health problem, then I
Yeah.
think that we are playing a trick over there. Uh,
Absolutely.
also want to focus on the narratives which drive the way we practice modern obstetrics, and I can talk a little bit more about these narratives a little later, and I can share with you my thoughts on that. But I know that I have already spoken a lot on this question, so I'll ask you to go ahead. There is, in fact, a lot
A lot.
that can be done, and there is a lot that I hope Foxy will be able to do, not only next year, but I think we're already doing a lot. Our current president, Dr. Rishikesh Pai, is really working very hard, and so are all the office bearers of the
Yes.
federation.
And we were pleased to host Dr. Rishikesh Pai a little earlier in the day for this conversation as well. And we've heard a lot about, I think what is very interesting that you mentioned, being sexual and reproductive health and fertility as one of the main concerns, and a lot of myth busting that you just did, because, not only is fertility not seen as a public health issue, overall women's health is also not framed as a public health issue. It's just, in our society, it's a bit, oh, it's a women's issue, like the women will take care of it. And a large impact of that is on fertility journeys of couples, where we have a lot of people who come and tell us that, aap inko bataiye, like talk to the wife, something must be the issue there, even though the data is very clear that at least 30%, challenges in fertility could be due to male factors as well, and that's not entirely addressed. So, sir, what I would love to hear from you is that, when we are talking about, stigma within clinics and radiology labs, especially with respect to sexual and reproductive health. We hear a lot about, say, somebody was saying yesterday in one of our panels that, a woman in one of the urban cities, she went to get a cervical vaccine or a cervical care screening. She was unmarried, she was in her late 30s, and the doctor asked her, why do you need it? You're not even married, etc. So, what are some ways in which, in clinic experience, especially with regard to sexual and reproductive health, be transformed as we step into the future?
So thank you. I think that's really goes to the heart of what I said when I talked about narratives. I
Yes.
think it essentially boils down to perhaps a misunderstanding
Yeah.
of how medicine works,
Yeah.
how obstetricians and gynecologists have to operate within the current context of the law,
Yeah.
okay, and how mere history taking is sometimes misconstrued as being judgmental. Okay, now this is not to say that there are no judgmental gynecologists. That would be
Mm.
I'm not trying to say that. I'm sure there are some, but I can assure you. And if you look at my Twitter bio, you'll see that I have written, I believe in the altruistic gene of healthcare providers. I have always strongly felt that if it was only about making money, people who become doctors could have easily chosen other professions. But
Yeah.
I think there is
That's
something more than money which drives doctors. You don't become a doctor simply to make money. It's my belief. Again, I may be wrong. This is the prevailing narrative that doctors become doctors to make money, but I don't agree with it. If it was just about making money, it would be so much more than that. But coming back to your question about stigma, like you mentioned, that there was this lady and then she felt offended or she felt stigmatized or she felt judged upon because she was asked, why do you need the cervical cancer vaccine?
mm. Yeah.
Because you're well, the point here is that cervical cancer vaccine works best before the first intercourse.
Mm.
And if
Yeah.
the gynecologist, just imagine this gynecologist would have asked her, you're unmarried, that's fine. Are you having intercourse? Would that have been construed in the right way? Or
Mm.
would that also have offended her and made her feel judged upon? And this is
Mm.
a valid medical question to be asked. Now, perhaps this question can be framed in a little better way. Perhaps the patient can be told, I need to ask you this because the cervical cancer vaccine ideally works best before the
Yeah.
first intercourse.
Yeah.
Perhaps for asking young adolescents who come to our clinic about whether they are sexually active or not, we can
Yeah.
tell them that there is something called the POXO Act in our country.
Yes.
And
Yes.
if I don't know whether you're sexually active or not, the obstetrician and gynecologist, any healthcare provider, can actually be accused of aiding and abetting
Yeah.
and breaking the POXO Act.
Yeah.
And
Yeah. That's true.
the, this is where that question about sexual activity comes from. It's not a morbid interest in sexuality of adolescents. So I think there is a lot of gap
Yeah.
in communication, perhaps. There is a lot of gap in understanding. And this
Yeah.
whole narrative that healthcare providers in general are judgmental, are
Mm.
opinionated,
Mm.
think that they impose their value judgments on adolescents and unmarried women and so on and so forth. I think it's become such an accepted norm that nobody has questioned the evidence surrounding it. This is one place where anecdotes have become evidence. Okay, and what I would like to do in my year is study the evidence, and
Yeah.
if the evidence shows that yes, providers are judgmental, providers are biased, I think we have simply not gone one step further and asked why are providers or the healthcare ecosystem biased and judgmental. We
Yeah.
have just made an assumption. We have said, all right, there's limited evidence shows it, and now it's become the norm, and we do these interventions, value clarification exercises, and so on and so forth. The problem is, who is judgmental when a woman steps into a clinic? Is it the provider? Is it the receptionist who looks askew at an unmarried pregnant woman? Is it the nurse who is taking a blood pressure or keep making her ready for an examination and saying that, well, you're unmarried, why do you need a vaginal examination? Or is it the provider? I mean, the whole emphasis of both the evidence and the intervention is so much on the provider that you are neglecting the fact that there's an entire health ecosystem surrounding the provider. And the stigma may not arise from the provider, it may arise from this health ecosystem and it's attributed to the provider. Now again, let me quantify, or let me sort of qualify this statement by saying I'm not saying that there are non-judgment there are judgmental providers. I'm not saying there are no judgmental providers. But there are judgmental providers, there are judgmental receptionists, there are judgmental nurses, but then there is a very judgmental community also. And
Absolutely.
the mind frame with which
Yeah.
women who need SRH in these special situations walk into a clinic reflects that.
Yeah. Yeah.
You see,
Yeah.
so I think there is this whole gap in communication. I think there is this whole gap in perhaps the fact that we have not been able to convey to the community why we do certain things. And I think that
Absolutely.
it's hugely important to fill this gap. I don't
Yeah.
think it's
Yeah.
only possible with physicians, but at least let's start by looking at the evidence, and let us start by asking the question: why is the healthcare system biased or judgmental? Because if you design an intervention with an assumption, what you get at the end of the intervention is simply how do I say, a hypothesis will not valid, because the hypothesis was based on assumption and not fact. So I think
Yeah.
we need to take the next step where we say that all right, we find providers are judgmental. Are they judgmental? What is judgmental? Because judgmental is a qualitative thing. For the provider, I may be asking a question, and I would like to believe I'm non-judgmental, but the patient sitting in front of me may feel that I'm judgmental. Where do we find a way of bridging this gap?
That's right. That's
Right?
right.
So we have
Yeah.
to understand the expectations of the community, and we have to understand the expectations of the physicians. But so far, I believe that all evidence and literature focuses on the expectation of the community. There's hardly anything which focuses on the expectation of the physician,
Yeah.
or says that, all right, if you are unmarried, if you are an adolescent, you go to a physician, you will be asked whether you're sexually active or not, and we are supposed to ask that because there are laws which govern us. And if we don't ask, then we are culpable under the law.
Yeah.
You
Yeah.
see, so
Yeah.
I think these are all so many, as I said, there is so much to do. But I think that this is a very, very important area which needs to be addressed. So, coming to stigma, I think, stigma doesn't arise only from the healthcare unit. Stigma is something which is carried from the community into the clinic,
That's right.
right? And if you want to address stigma within a clinic, I believe it's not enough to address it only within the clinic. You need to broad base this intervention, and you cannot say that, all right, I'll talk to the doctor, I'll do value clarification exercises, and then stigma will disappear. It doesn't disappear. We have done work on stigma, particularly with abortion, and we have consistently found that yes, there is an element of stigma, or there is stigma within the healthcare ecosystem, but a lot of it is carried from the community into the healthcare ecosystem, because we are part of the community at the end of the day. We are not separate from the community. So if there's stigma in the community, it is going to get carried over. So it's
That's
that issue. We need to broad base address that, and we need to address the expectations, and we need to make patients understand. So for me, what would be more important is telling physicians that if you're asking something, please explain why you're asking it.
that's right.
And if
That's
the
right.
patient perceives that the physician is being judgmental, the patient should ask the physician, why are you asking me this? What is the motivation behind asking me this? And perhaps if this kind of a dialogue occurs both in evidence literature and in real life, I think this whole uh, issue about stigma can be addressed much better, rather than just doing academic exercises with patients.
That's right.
Sorry,
And I think,
I spoke a little more about that because I feel very strongly about this,
yeah,
because I
yeah.
don't, I really, I'm really so distressed,
Mhm.
when I read these things.
Yeah.
Women have the right to safe, dignified, efficient, efficacious care. And if they don't get it, then somewhere there is a failure. But is the failure that of the physician or the system or the
Yeah.
community at large? And
Yeah.
I think this issue really needs to be addressed a little more deeply.
That's right. No, Doctor, I think you raised a couple of very important points, something that we've been talking about for the last few days. That number one is the framework of the law that exists, especially when it comes to things like MTP or the POXO law, etc. That there is a framework of the law, and there is of course a framework of culture. Doctors are at the end of the day part of the same culture and have to be
Exactly.
respectful of that culture. Or at least like be aware that that culture is, for example, we see this a lot in fertility related conversations, and a lot of fertility doctors talk about this, that when there is a couple that comes in between, for a consultation. It's all progressive. It's a great conversation. But then when there's a senior member coming in with the couple, then the conversation seems to change in nature. And then in that case, the doctor has no option but to sort of, go with the flow. So yeah, and I think what you very critically mentioned over here is that the role of, say, sexual history, etc., in the treatment that might happen. For example, say in PCOS, in endometriosis. I think a lot of women actually, the what, why, and what next of healthcare that we talk about. What is
Sure.
PCOS or endometriosis? Why is this happening to me? What are the various interconnected pieces that might have an
Sure.
impact? These things are actually people are not very aware, even after having these conditions for years. And I think the communication part is something that is very critical, and we completely agree with that. So coming to that, so you spoke a lot about the data aspect, which is actually very critical. I mean, even now when we're writing reports and things about healthcare statistics, a lot of it is derivative of what is happening back in the US, etc.
Exactly.
So, so even for things like like how many women in India currently have endometriosis or things like that, how many of them have been misdiagnosed, etc. What are some ways in which our data around this can be more robust? How can we develop better metrics of management and tracking? I know it's a very large. I know I'm throwing one large question at you, again and again. My apologies for that, but there's just if we can like briefly touch upon better ways of robust data management when it comes to very basic things like how many women in India currently have endometriosis or something like that.
So, I mean, endometriosis is one thing, but yeah, data has always been a problem. So
Yeah.
we, you could say that we are a very rich country in terms of the number of patients that we have, but we are a very poor country in terms of the data that is saved
Yeah,
for these patients. Uh,
that's
you know, Data rich, evidence poor, as some people have called it.
yeah,
The issue that occurs to me really is, for example, endometriosis. All right. We know that certain percentage of women suffer from endometriosis. Now, how will it help us to quantify that?
yeah,
Because this is a real incidence. right? So I'll just give you an example from my practice. I run a lot of IVF centers in a, you know, in small cities and towns. And a few years back, I noticed that in my practice in the urban areas, the incidence of endometriosis was rising and the
Yeah.
incidence of pelvic tuberculosis was decreasing. But in the rural areas where I was practicing or where I was assisting for IVF, the incidence of pelvic tuberculosis was still high, whereas endometriosis is not that high. So it was almost as if, in the urban areas, pelvic tuberculosis was being replaced by endometriosis in terms of the number of patients who came to us for fertility. So my question really, when you talk about data, is when you want to gather data, I think we should know what we are going to do with that data.
Yes.
Otherwise, what's the point of the data? If you know, for example, that approximately 7-8%, which is these many thousand or lakh women have endometriosis, what are you going to do with that data?
Yeah.
Are you going to say that therefore endometriosis is a significant problem? We already know endometriosis is a significant problem. Okay, so I think we would be better served by interventional data, saying that these many women had endometriosis and these many women had an unmet need, and then we can focus on addressing that unmet need. For me, that data would be much more important than just a registry of women who had endometriosis,
Yeah.
because that data is going to help me to fill the gaps of where services are lacking, where women don't have access, and so on and so forth. How can we collect the data? I think it's a very lazy answer to say digitization,
Yeah, of
because I think
course.
people don't understand the scope of digitization. And
That's
at the end of the day, digitization depends on the data that is fed into it. So,
right.
what is the incentive for either a patient or a doctor to report the data? So I've been a part of several registries in the past where we have asked several specialties, not only our specialty, to fill in data, and the response has never been very good. Okay, so as I said, if there is a point to the data, if we are going to achieve a concrete outcome as a result of that data, then it's a good idea to get the data. And obviously, the way to get data is digitization. The problem is, one, who will give the data, and second, how reliable is the data.
Yeah,
And
reliable,
therefore,
exactly.
data gathering is an extraordinarily expensive exercise, which I think people don't realize or don't appreciate. It takes money to get data. Until
That's
we
right.
don't get adequate funding, or I mean, and I always say this, that sometimes the private sector is a little, I don't know if I may say so, misunderstood in terms of its financial outlook. So you must understand that the private sector, the person who runs a hospital is an entrepreneur, and while making money or is of course one of the goals of that business, so is ease of business, right? So incentives can be provided either by paying, which is difficult because of the scale of the healthcare issues in our country. But you could also, for example, incentivize by making an ease of business. So if I am running a nursing home, I take somewhere between 20 to 27 licenses, some of them renewable annually, to run my business.
Yeah.
So, for example, in public-private partnerships, the government could simply say that if you are participate in this public-private partnership, I'll give you a single window access, and that incentivize me much more than anything which the government can pay. So I
Yeah.
think we are looking at this whole issue of data gathering in a very siloed way. We are not really looking at it in the outcome of that data gathering, the process
That's
of the data gathering, the funding of
right.
the data gathering, the reliability of the data, and then taking all this together, what data do we really want?
Yeah.
You see, so I think till we don't arrive at all this, I think it is a little premature to talk about the fact that every woman in this country should have access to data about what other women are going through or what is happening to other women. I'm sorry,
That's
it's a long answer to a short question, but
No, no, no. It was no, but this is very important. You know, the pillars of data gathering, which is, I think, the most important thing is reliability and the outcome that we expect. There's no doubt about that because, like you said, data is just data until you make it tell a story, right? And I think a lot of the things that we are currently, I think, grappling with, even as a women's health company, is precisely this: that the unmet need, the gap. That okay, now the diagnosis has happened. What next? So, in that spirit, doctor, I think in the interest of time, in conclusion, I would love to ask you that there are many gaps that exist, obviously, in healthcare to be fixed. What collaborations and collaborative possibilities do you foresee between digital health companies and doctors and clinical sort of setups that could bridge some of these gaps, especially when it comes to unmet needs around the non-clinical aspects of health, which is your nutrition, your lifestyle, your emotional health, etc. What possibilities do you see there?
I think there are enormous possibilities, if you ask me. But there are two issues. One issue is the relation between causality and association. And there's a lot of confusion about this. Typically, people want very pat answers. All right, if I do this, I will get this. If I don't do this, then I will not get endometriosis. But if I
Yeah,
do this, I will get endometriosis.
yeah,
But
yeah, that's right.
most of these pathologies, which are to do with nutrition and so on and so forth, are so multifactorial that it's a whole lot of things which come together to either prevent or promote.
Yeah,
And there are no easy answers over here. So we first of all have to inculcate this nuance about association and causality. If
yeah.
something is associated, it's not a cause.
Yes,
Okay.
exactly.
So, for example, women who have fibroids are also known to have associations with endometriosis. But that you cannot say that fibroids cause endometriosis,
Cause endometriosis. That's right.
right?
Absolutely.
So the first thing is this whole differentiation between association and causality. That's really key. And this whole has to be inculcated not only in healthcare providers but also in the community. And I think any femtech company would do a great service if they can emphasize this difference.
That's right.
I think
That's
the
right.
other association, which would really be the other thing which a femtech company would really very should do is to engage with providers as human resource, not simply as, so for example, there are companies which say that, all right, you pay us so much and then we'll give you appointments and we'll this that. That's not really what femtech is about. No, femtech is about enabling women to achieve the best possible health.
Yes.
And
Absolutely.
visiting a physician is only one of that, because
100%.
in that
100%.
whole process, visiting a physician is perhaps the smallest part of
Mm-hmm.
what that femtech company should be doing. So utilize physicians, utilize our expertise as resource to try and reach out to as many women as possible to ensure that they get the best possible health with the least possible effort, if that is possible at all.
Yeah. And I think what you said is very important that many a time, even especially for women, even walking up and going to the physician, that itself takes a whole lot of awareness that the symptoms that you're facing, this is, like this is not something that you should delay for another month or 6 months, etc. So that is also like, whether prevention or whatever it is, symptoms are not to be ignored. If you're feeling something, it's real, go talk to a doctor who will, maybe help you manage it at the right time. So, thank you so much, doctor. I know that you're in the middle of your very busy day. You've given us a lot of your valuable time, and not only that, a lot of important threads that we need to tug at as we look for answers and solutions. When it comes to women's health, whether it is reliability of data, which is being collected in an outcome-oriented manner, or it is better in clinic communication and understanding what are the legal frameworks and cultural frameworks within which both the doctors and the patient is working with, and also the idea of really looking at doctors as the central core around which many spokes of the wheel sort of radiate from. So there is community work, there's mental health, there's role of digitization in a very sort of outcome oriented way, and the doctors are of course at the center of it all. So we look forward to more such conversations and collaboration in the future, doctor, and thank you so much for your time. We deeply appreciate it.
Thank you, Swarnima. But if I may, I would actually like to say that it should be the woman who's at the center of it all, not the doctor.
Absolutely. Definitely. Yeah, absolutely. Thank you so much for that. Good. I think this is something that we really have to, also reimagine, as we think of healthcare. Thank you so much, doctor. We really appreciate your time and we hope to keep talking. Thank you.
Thank you.